Hi, everyone. Thank you for joining today's webinar, sponsored by Withum and Sage Growth Partners, the No Surprises Act, How to Protect and Grow Your Practice. Today's program will be moderated by Dominic Segala, Market Leader of Withum's Healthcare Advisory Services, and Dan D'Orazio, CEO of Sage Growth Partners. And we are thrilled to have Dr. Karimi of New Jersey Brain and Spine and Dr. Abrams of Brain and Spine Surgeons of New York with us to lead the discussion. At the bottom of the toolbar on the right of your screen, you will see a questions box. Feel free to send us your questions during the presentation. We will do our best to address them at the end. Thank you, and I'll now turn it over to Dominic.
Thank you, Rachel. I'd like to thank everyone for joining this today. It's going to be a very interesting discussion. I think it's relevant with everything that's going on. And special thanks to Dr. Karimi and Dr. Abrams for joining us as two leaders of our practices, not only great clinicians, great businessmen, and really to hear from them how they're sort of, leading their practices through these murky waters post the No Surprises Act. And I think that's a good place to kick off, is with the No Surprises Act. We will get into a little high level and turn it over to Dr. Karimi. But really, I think everyone is aware, back in January of 22, something called the No Surprises Act, which had been in discussion for probably almost a year, came about. I think we'll all agree that it is good for the patient, but clearly it comes with a financial hit to many practices, specifically those that are specialty providers and those that in the past, most of their arrangements were out of network. And really what the No Surprises Act does is it's, as it says, no surprise to the patients. So depending on the situation now, in the past, an out-of-network provider would get paid at a higher reimbursement rate. Because of these changes, if you continue to be out of network with payers, you're only going to get paid at that in-network rate. So clearly, from a leadership standpoint of Dr. Karimi, Dr. Abrams, the financial impact and how they now will grow their practice on a go-forward basis, in a world of consumerism with the patients, in marketing changing, and something Dan and I have spoke about, in the past, your competition was geographically located next to you. Well, now in this world of virtual care, it's a whole different marketplace. Your competition could be on the West Coast, it could be down in South Florida because of virtual care. So with this No Surprises Act, again, financial hardship, yes, but a lot of more detailed difficulties within the practice. You now have to give consents to patients. You have additional paperwork. You have something called an arbitration process, which if you don't agree with the amount of a qualified payment that came back from the payer, you have to go through this process. And then you have to go through an independent dispute resolution. So not only is it difficult, again, from less reimbursement, but if you start to think about the workflow and the difficulties, we all know billing and collection is difficult as it is. And you start to now go through this and have to add all this to your billers. So with that being said, over to Dan, who will take from here.
Yeah, Dominic, thank you for your time. Thank you, everyone, for joining, especially Dr. Karimi, Dr. Abrams, and our guests today. As we thought about this topic of no surprises, we specifically thought about protection and growth. From the protection angle, there are things that have happened that are clearly out of our control and your control. So right there was the law, and now there's the regulatory component of this, and a lot happens in the regulatory process. And so the first thing we'd love Dr. Karimi and Dr. Abrams to talk about is, as the No Surprises Act is here, and in our experience in working with a lot of the regulation that physicians have faced over the years, some of this takes time to catch up and for everyone to figure this out, and especially as it's moving and changing. What we want to do today is give you a perspective, if you're ahead or maybe if you haven't started, some of the things that you really want to be considering. So Dr. Karimi, the first thing I want to discuss, and as well as with Dr. Abrams, is the protection piece. So the regulation is here. There are a lot of things that your practice has to do to be in compliance. We'll then move to the growth component. But as you, Dr. Karimi, have looked at this with your partners, and please feel free to give the audience a little background about your group as well, Dr. Abrams. How have you thought about the initial steps of complying and getting the workflow and the staff ready to address what we know at this point?
Thanks, Dan. So a little background. I am a member, partner of around 15 physician group of specialty neurosurgeons in northern New Jersey and the New York metro area. We are basically an in-network group for the majority of insured in the state of New Jersey. However, we're not in every network, so there is a substantial amount of out-of-network emergency care that we provide, specialty neurosurgical services, spine, trauma, neuro-oncology, vascular neurosurgery, pediatric neurosurgery, etc. So out-of-network care has been a part of our business model for a while, and we've had a lot of experience with that. However, with the new law, everything has been turned completely upside down, and even trying to be ahead of this, you're still by definition playing catch up because nobody really fully understands the implications of the law completely just yet. As a practice, the first thing we had to look at was being in compliance. The regulations are very specific. There's no doctor I'm aware of who would be opposed to the patient protections here. The patients should be completely held harmless, especially during a life-threatening emergency event when they're in a hospital receiving emergency stabilizing care. That part of it, I think, speaks for itself. The patient should only be responsible for their in-network co-pays, etc., regardless of whether or not the providers are in or out of their network, period. The second part of this, I think the biggest part is the patient protections, but the other larger parts of the law are the requirements for notifying these patients, which are basically disclosure notices against, regarding their protections against surprise billing. There's a consent and waiver form for all out-of-network and self-pay patients, and self-pay means uninsured or patients who are paying cash for one reason or another. And then there's also the final part is the good faith estimate, which is just that, an estimate of the cost of providing their care. And these things have to be delivered within, 3 days prior to an elective or semi-elective procedure. But of course, you can't get these consents and notices done on emergency basis. So we had to, as a group, network with law firms and advisors on how to become compliant with the law immediately in January, because there are some penalties associated with non-compliance. The second part of this, and that process took several months. I think we have it 90% ironed out. There's little differences in how we deliver information to the patients, but we are now thankfully in compliance, and I'd encourage any group out there to make sure you consult your attorneys to make sure that your paperwork and your forms are in compliance with the federal law. A lot of these are boilerplate forms that they are given out by the government, and you have to be using the correct forms and giving it to patients within the time frame specified. The other parts of this law that I think are still yet to be clarified for at least the next several months or maybe even several years is the arbitration process, which we can get on into a little bit later. And there's lots of considerations with the federal arbitration process because the arbiters have very specific framework by which they are to decide the appropriate reimbursement rate. A lot of this is set forth in the actual act as well as in the regulations from CMS and HHS, which were released not too long ago, and also the subject of some lawsuits that had remanded some regulations back to HHS for revision.
Thank you, Dr. Karimi. Dr. Abrams, relative to the components that Dr. Karimi talked about, the other practices that are here listening, what would you share about how this has impacted your practice, your partners, your workflows, your readiness? Any tips or perspective you can share?
My name's John Abrams. Thanks for the introduction, Dan and Dominic. I am a neurosurgeon. I run a group about the same size of Reza's. we're 21 physicians, probably half neurosurgeons, 3 orthopedic spine. We now have a neurologist, neuropsychologist. We have 5 pain management with anesthesia, ENT, plastic surgery, and predominantly neurosurgery. We're different than Rez's group, and it's interesting because hearing him speak, kind of reminded me. I know him very well. He has a wonderful group, but Reza, please correct me if I'm wrong. The one difference is we cover multiple community hospitals. I think Rez's group covers Hackensack Medical, which is on par with any of the larger hospitals in the city, and they see a lot more call than we do. Secondly, New York went through this in 2015-16. So New York went through a No Surprise Act, and that was one thing. And actually, there were almost no arbitrations. I would say we were about 70% to 80% elective, 20 to 30% urge emerge. Over the past 5 years, our urge emerge volume went down substantially because of the competing hospitals in New York all wanted to come up here and be part of some gravy train they thought existed, which it didn't. So share call at our main hospitals at least 50% with the physicians who came up here designated by Northwell, Cornell, Columbia, and Montefiore. Now, what's interesting is that before the No Surprise Act, we had problems in New York. I don't know if you had this in Jersey. We were getting a decent multiple out of network for elective cases. And Blue Cross Blue Shield, Aetna, United, Oxford arbitrarily just dropped them over the past 18 months to a level that was below Medicare. And so that was the problem we're having in New York. Secondly, in 2022, there was only one insurance plan that pays decent out of network. That is the New York State Health Insurance Plan, NYSHIP, which is the plan for all of the teachers, police, firemen, and whatnot. They are now vacillating between the state versus the federal. And they are trying to justify that they do not have to pay the Fair Health out of network, which is what the basis of New York is. And so New York went through this because of the Ingenix lawsuit in 2008. They recreated the out of network prices, and it was a weighted average of the volume of a particular code and a region. Now, we were lucky because we were doing most of the work, but over time that's transformed. As a group in the tri-state area, and I'm sure Ray's has the same problem we have, the cost to open our front doors are exorbitant. Getting paid 1, 2, even 3 times Medicare, it's going to be very hard for a practice to sustain itself. So we had to go in network, which has taken quite a long time. And we signed with Cigna, we signed with Aetna, and we're trying to sign with Blue Cross. They're very difficult. We signed with United, Oxford, and we started to negotiate with NYSHIP, but then they came to the table, gave us a horrible rate. We walked away. They came back with a really good rate, but they said, well, wait a minute, we're not sure because they're trying to jump on the federal instead of what we have in New York that's existing. And as Dominic knows,
Dr. Abrams, I think we lost you there for a second.
private practice for men.
Dr. Abrams, we might be losing you just a little bit. I think that's better.
While we're trying to get him back,
And as similar as the problems are, they're still very different.
yeah. So, Dr. Abrams, I think this is really interesting for the audience. You guys have been ahead of this because of your experience in New York. For the other folks that are staring down this barrel, Dr. Karimi and others included, what have been the most significant impacts sort of to practice structure? Obviously, economics have changed. What can you share with others that they could start to look forward and expect around some of the changes they need to make outside of obviously the insurance negotiations, but in terms of how you're dealing with patients, how you're running your practice? I think that would be really interesting for folks to hear.
Reza, go ahead. You want to go first?
Sure. So Dr. Abrahams, we've been through a lot of the same back and forth with the insurers, and it is true that the overhead up here is very high, and 2-3x Medicare rates just will not work, period. Everything comes down to the federal IDR process. Of course, we have, we hear that New Jersey, which has its own out-of-network laws for state-based, state-governed plans, which are at Fair Health, those are favorable for practices, at least in neurosurgery, not so much for other specialties, including cardiology, et cetera. But the Fair Health basis is something that is sustainable for us for the New Jersey governed plans. The federal law, the No Surprises Act, does not apply to those. It applies to the ERISA governed plans, which in our market is the majority of our out-of-network rates, case volume. Hold on, let me just go back to this. So interestingly, we have just been informed that the New Jersey arbitration companies, due to confusion about which guidelines to use, state or federal, for the appropriate reimbursement amount, they asked for clarification from CMS, which is forthcoming, but the entire arbitration process, which was supposed to start January, February, has been delayed now almost 7 months and with no end in sight. Our ability to negotiate anything with insurance companies is predicated on the ability to go out of network. So the arbitration result is going to determine a lot of things for practices like ours. If we have the state-based plans going over to federal arbitration guidelines, and federal arbitration guidelines are very unfavorable, we will have to make some potential drastic changes to the way we practice, which only means one thing: cutting overhead. I'm not sure how much you can cut. For example, in our group with about a dozen neurosurgeons and then other non-neurosurgeons, we have 65 full-time employees, including 11 physician's assistants, and the whole kit and caboodle. It is not possible to have that kind of staff in a medical practice if you're being paid at Medicare rates for anything and everything you do.
Yeah, thank you, Dr. Karimi. Dr. Abrahams, would you like to share anything before we ask some other questions around those issues?
Yeah, no, I mean, I agree. I think what physicians are not good at on a state basis is banding together to protect things. The physicians, neurosurgeons in New York, a significant number in New Jersey, and we have never been good, not just neurosurgeons, all physicians at moving in the same direction. Now, New Jersey now has a behemoth in its backyard in Summit Healthcare, who now has CityMD, Summit Medical. They just picked up this urology group, and they're looking at everything and anything they can. That's a different model for neurosurgery. They're basing this on being an ACO, an ACO, and it's a different revenue model. Neurosurgeons or surgeons in general, orthopedic, neurosurgery, have to be able to develop other revenue models, because this is always going to be a problem. And in the way Reza described it, we're having the same problem. We already lost ERISA. The ERISA plans are gone. They basically started to reimburse us. Blue Cross was reimbursing us under Medicare. And over the past 18 months, yes, they all dropped to a point where we've got nothing from them. Some ER cases, but we didn't have enough volume to justify it. The state-backed plans, as he alluded to, we're having the same issue. They are trying to become federally regulated, and they're waiting to see if they can use that arbitration process. And that's the only plan that's paying in New York State. That's it.
Mm-hmm. Yeah, it's daunting from a business perspective. I know, Dr. Karimi, you and I'm sure Dr. Abrahams and plenty of other physicians have been providing care that is uncompensated or drastically reduced for a very long time, which makes this discussion even more difficult. So I want to transition to the other side of this coin. And it's not as if it's an easy formula, but when we've talked about protecting, right, there are certain things that we've discussed around the regulation that are non-negotiable. But from a perspective of receiving a lot less revenue than you've traditionally have, in light of a more consumer-driven market, I want to turn the conversation to other components that you've been thinking about to grow your practice, even in light of this. And I know it's not as if you've sat back and said, I only need to grow my practice because the No Surprises Act has shown up, right? This has been something you've been dealing with for a long time. So Dr. Karimi, the first area, and Dr. Abrahams I'd like to touch on, is the notion of quality, which is very difficult to measure in healthcare. But in our conversations, the importance of quality, both from a consumer and a patient perspective, but also from a network perspective, probably becomes even more important. Can you just start to share your thoughts around how you've been thinking about quality in general and in light of this going forward, and how it will maybe change the way you operate or enhance the way you operate?
Sure. So, of course, every physician out there is always about quality first and foremost. The focus for this issue is that in the arbitration process and the IDR, one of the few things that you can bring to that discussion or to the IDR arbitration process is a demonstration of the, quote, level of training, experience, and quality and outcomes measurements of the provider. And that can be used by the arbiter to determine an award in favor of the provider when determining the appropriate amount. It's one of the only things you can bring to the discussion. You can bring your previous contracted rate with that plan. You can bring your what is your geographic catchment area, the complexity of the case, the teaching status and scope of services of your group, and the demonstration of good faith efforts to enter into in-network agreements with that plan. So with respect to quality, what we have done is we have tried to, and we've been doing this for years now, but now we've formalized it and taken it across the different subspecialties of neurosurgery. We've been putting together documentation of our length of stay, complication rates, clinical outcomes for some of the more complex cases as a demonstration of superior quality, which hopefully will sway an arbiter to pick during the baseball style negotiation to pick our offer for payment. So you have to do an internal audit. You have to, for example, look back on 1 year's worth of spinal fusions. What was your length of stay? How does that compare to other published norms? How about your patient satisfaction index, readmission rate, etc.? That's something very important that we've started to do that we think will have some impact during the arbitration process. We hope it does, because there's not much else we can do during the arbitration other than trying to demonstrate superior quality and getting favorable reimbursements at arbitration. In addition to that, you can look along the same lines of efficiency in terms of quality. Perhaps there's some inefficiencies in the group. Perhaps there are some ways that we can streamline the patient experience and perhaps have less staff up front just to get the patient in the door. Should you use a call center rather than having 3 or 4 full-time employees screening your calls, getting the patient's phone calls triaged to the appropriate person? That actually is a measure of quality because it's also relating to the patient experience, but also it can be used to streamline your organization, hopefully cut some costs and raise the bottom line. Ancillaries are something you can look at doing to increase your bottom line as well. That's a separate discussion because those are all also affected by this legislation. For example, neuromonitoring is an ancillary that many neurosurgical groups use as an ancillary income stream. However, the neuromonitoring reimbursements are completely going to be covered by the No Surprises Act, and we don't know how those are going to reimburse. So maybe now is not the right time to make that, $250,000 or $500,000 investment into neuromonitoring equipment until you see what happens to the neuromonitoring reimbursements. But the focus for us is now looking at quality of outcomes for vascular, tumor, and spine neurosurgery and presenting those to the arbitration.
Dr. Abrams, I know you've been focused on this as well with capturing some of the feedback from your patients and this notion of quality. Can you share more about what you've been doing?
Sure. About 2 years ago, we started to write our own software, and very, along same lines along what Raz is doing, but we automated it, and we started out by collecting real outcome data. And what I say to all my friends who are spine surgeons, and I say, after you do a lumbar fusion, how many people go back to work? Who's off pain meds? Who went to therapy? Who needed physical therapy? And really get at the granular level of that care, because physical therapy out-of-pocket expenses can range to $60 to $80 per visit. It's not completely covered. And we built a software program out of the office where every surgical patient is entered, and they get a series of questions that are automated to their cell phone as text. So for instance, if you're going to have a microdisc on July 1st, the coordinator puts you in the system. You got to fill in 5 fields: name, date of birth, surgeon, diagnosis, date of surgery, hospital, and that's it. It's starting to pull from the EMR, but it hasn't been perfected. Once you're put in the system, if your surgery is July 1st, 3 days before surgery, you will get 5 basic questions. It comes into your cell phone as a text. You click a link, you get a HIPAA compliant browser. It takes you about 3 seconds to answer. Then what happens is you get questions 3 days after surgery, 3 days, 7 days, a month, 3 months, and a year. And the reason we did this is because you forget in the office, patients don't like to fill out paperwork. They don't want to sit by a computer. The minute their visit is done, they want to be out the door. So now we have over 1,000 patients who we've collected outcome data. We call it best practices. And so what we also did is we normalized the amount of care after surgery, and we reduced the imaging by 50%. We reduced the visits by 50%, and we standardized it such that I went around and polled all the surgeons. How many x-rays do you get after fusions? How many CAT scans? How many MRIs? You can't imagine what people were doing. CAT scans every 6 months for 5 years. Ridiculous. We just do x-rays at a month, 3 months, a year, unless there's a problem. And now we have good data to show that that is what's going to be, that's what's very important. I think if you have a practice like Reza's where they have a significant relationship with a busy emergency room, and so they're probably seeing more complex cases than we see. We do not see we had one vascular person who's not that busy. We don't have a tried and true tumor program. We're predominantly spine. And I think what's going to happen is this data outcome, you're going to have to show them to get anything. And I think what they're going to end up doing is going to do what they do to hospitals. You're always going to get paid 80%, 90% at some point of what your fee is, and they're going to hold 10 to 20% back for quality. And if you don't have a certain quality, including patient satisfaction, then that's going to be the next thing that's going to happen. So we've invested a lot of time and money into the program, and we're using it. We use it for different programs within the practice. So because we have so much spine, we ventured out into other business models because I don't see this getting any better. And I think larger groups need to diversify. So we set up a quad A where we do our procedures. We got into ketamine because we have so many spine patients. We built the software platform, and there's a few other businesses. We're going to put up our concussion program. So concussion is a huge business that follows spine patients, because a lot of the spine patients come through workers' comp at no fault. Well, a lot of these patients also have concussion injuries, and there aren't a lot of simple programs to encounter those patients and provide therapy. So that's where our business model is a little different.
Yeah, that's Dr. Abrams, are you still there?
Yeah.
Okay. I find that fascinating and empowering that you're taking those steps. I'm curious, you talked about how you started to learn more probably about clinical pathways, even of your partners. What has the response been from the patients as you've continued to engage them? Because I know patient satisfaction, and I use the word consumerism lightly, because healthcare is different, but we are starting to learn more, and we're all patients, we're all consumers. How has the response been from your patients as you're continuing to stay connected to them?
Well, what we figured out before we wrote the software, we were handing out paper forms, and of course the secretaries all complained. Patients did not want to sit in the office and do anything. We would give them a laptop. They hated the laptop. They then wanted to, then we tried to send emails. None of that worked. We were able to take our response rate that was 5 to 10%. We were able to get up to 40%. Second of all, we submitted an abstract which was published, which showed staff time for our follow-up went from 60 hours a month to 20 hours a month. We were able to engage the patients, cut the costs, and actually get useful data that we used to go out and publish. And so, look, I think from a patient satisfaction, I think the patients are happier. You know, with a patient, less is more, right? So the less they have to do, the happier they are. And, you know, we've had the program out for about a year. We just added it to pain management. We just added it to ketamine. And so it really is, you know, malleable. You can use this for any medical outcome. And I think the patients are happy. I don't have exact data to show that the satisfaction rate went up from A to B.
Sure. Yeah, and the other thing I'm curious about is, as it sounds like you've started to reduce the total cost of care in terms of your clinical pathways, you know, both in terms of procedures you might be doing, but also your staff time. Are you thinking forward in terms of how you'll use that data in, obviously there's these negotiations, but anything relative to other, you know, narrow networks or other kind of relationships you're building in the market with your total cost of care reductions you're able to start to demonstrate?
Because the majority of our practice is spine, we are now engaged in putting an ASC in our building, because that's the next step, is going out and taking the risk for the patient, taking the whole care continuum from the minute we see the patient to doing the surgery. Now, lumbar fusions are mostly going home the next day, which means we can put them in a 23-hour hold. Anterior cervicals are going home the same day, microdiscs, sacroiliac fusions, kyphoplasties, all these procedures are going to be pulled out of the hospital. They're too expensive. And what we're going to have to do, although we try to negotiate with hospitals, we always get treated like we're second-class citizens because we're not on their payroll. They can't control us. The only way I can compete with the only way I can get a hospital to do anything is to compete with them head-to-head. And so my goal is to pull as much as I can out of the hospital and put into my building so I can compete with them at cost. And that's what, and moving forward, if you have the outcome data and you're cheaper, you're going to get the better rate. And we can standardize it, because we won't be as big as some of the competitors. Northwell Health is 23 hospitals. They must have 100 spine surgeons. So to standardize something with 100 spine surgeons, very difficult. To standardize it with 20 spine surgeons, I could probably do that.
Yeah, I love you're using your leverage right here and your size to your advantage, which oftentimes, you know, folks might look at as the disadvantage, and love the perspective that you're bringing to this. Dr. Karimi, we've had the fortune of working with your group from a marketing perspective. Can you share how you've been thinking about the investments you've made in marketing in general, and why you've done that, and how you think those kind of efforts are going to be important, both in light of the No Surprises Act, but also some of these issues of consumerism and being provider of choice? You're in a very competitive market. So can you share some thoughts about why you've decided to go down that path and how it's prepared you for the future?
Sure. So I look at the marketing nowadays with two components. One of them is the basic have-tos, which is a lot. You have to have a strong electronic presence, internet presence, because the first thing that patients do, whether they're referred to you by their best friend or by their family doc, is they're going to Google you. They're going to look at where you've trained. They're going to look at your education, and mostly they're going to look at how patients rate you. It's a lot of work to stay on top of that, to make sure that it's always kept completely up to date, up to speed. If there's any negative reviews, you have to deal with those as best you can. You have to encourage patients to leave positive reviews when you feel they are likely to. So that is the absolute must have to, especially if you're in private practice. You have to have a very squeaky clean, rock solid online presence, and that is a form of marketing. The second part of it are the extras, which for a group like ours are also mandatory. In our market here in the Northeast, patients have a choice. They can go 5 miles in any direction and run into a neurosurgeon. They can go to larger institutions. They can go to Columbia, Cornell. They can go to some of the smaller satellite offices that those institutions have put into New Jersey because they noticed patients stopped crossing the bridge, a couple of decades ago for their care. So the other part of the marketing, which would be, for example, social media presence, having video content that's professionally done. And, some practices also advertise, we don't do this, but some advertise on billboards, some advertise in magazines and publications. I think you have to do at least a little bit of that just to keep your brand awareness out there, not only among patients, but also among other referring doctors. The other referring doctors have to be somewhat familiar with your practice. So marketing for us in the last 5 years with your assistance we've grown it substantially. We used to have the luxury of not really having to market ourselves, just to have a basic website. But I would say about 8 to 10 years ago, we realized that wasn't cutting it and that we were likely losing a lot to our competitors who had much better marketing in place. So with respect to the No Surprises Act, you really want to try to capture your market share, especially if you're in network with one plan that's been economically more productive than the others. You don't want those patients going elsewhere. You really need to attract as many patients as possible, because what you can make some of this up in volume. Maybe having increase your surgical volume by 10 or 15% can make a big difference in the physician take-home pay. Because everything else is just covering your very high overhead. So it's been a huge deal for us, and we've spent a lot of time and energy focusing on that, and it's only going to have to get more as a result of this legislation. The other thing that we've had, and again, this is so early into the No Surprises Act, the sun is still rising. We do not know all the details yet, but we still have a lot of out-of-network patients who come to see us in the office for elective surgery. And we've been able to get those patients pre-authorized by out-of-network insurance plans if the patient truly strongly demands that we are the surgeon for them. So once the patients get involved, the insurance companies are more likely to approve a procedure out of network with favorable rates at the behest of the patient. And that also starts with your marketing and advertisement. The patients will have an impression of you before they walk in the door. They just need to meet you to confirm if you're the right person for them. And we're talking about people who need to have a brain tumor removed, a discectomy, a spine fusion, an aneurysm coiled or clipped. They really need to vet you more than anything else in the consumer world that we live in. This is the most important thing. So I can't stress how important marketing is and will continue to be.
Yeah. Dr. Abrahams, how has your market presence or marketing or mind share impacted how you guys think or operate in this changing environment?
We've invested $500,000 a year into marketing. We have a full-time marketing person and a half FTE. So we're about 150 to 160,000 in personnel. We're 340 into actual marketing campaigns. It's a full-time job. We have a program. We meet every few weeks. We send out email blasts, newsletters. We developed a webinar program. We have a case study program. We created a yearly symposium. And then we built a research department, and that's where the software emanated from. But the research department is a full-time director and 2 half-times do data collection. We went through our lumbar and cervical fusions over the past 8 years. We have 5,000 cases, and we went through it to get length of stay and outcomes, and it was a Herculean effort, but we felt we had to do it because we don't know what we're going to be compared to moving forward. I think at some point the insurance companies outcome data on all their physicians, and they're just going to make it harder and harder for physicians to get paid. And I think the crux of that is having your own data. And again, it's costly. $250,000 is a lot of money for a private group to put up. And I constantly fight with the other surgeons because they don't want to pay it. And even though we have 21 physicians, nobody wants to pay 1 extra cent unless they can see it, the return on that investment. And that's been very hard for us on a private side. Having said that, we've been successful in submitting a fair number of abstracts, papers, and whatnot. Now, again, we're not curing cancer. We're doing outcomes research, and that's what we see. We do not see a large number of brain tumors. We don't have clinical trials set up, and most of those patients in this area, they go directly to the city. And in terms of vascular, we talked about, we have a decent functional program, not that busy. It's hard for us to build, the tertiary care neurosurgery because we don't have a hospital up here that we're friendly enough with to do so.
Yeah, I really appreciate sort of the honesty of the discussion around investments that you need to make in data or marketing, right? Because money's tighter and tighter, but as we look forward without data, without analytics, without marketing, I think this gets even that much more difficult. Dr. Karimi, we were talking about the role of analytics and data, and can you share how that has been changing in your organization? I think you've been chasing the data. It's not easy, but how do you see that role changing in your practice overall in the next several years?
I mean, Doc, did I lose you for a second there? Sorry, the call coming in. It's very important, and the key to any of these negotiations, whether it's a hospital or even the insurance companies, is having more data than they have when you sit down at the table. The data that we have looked at has been purely outcomes based because that's what matters for these discussions with the insurance companies and with the hospital. The hospitals also do apply pressure to us with respect to quality outcomes. They like to look at length of stay and readmission rates for obvious reasons. We like to look at that plus the actual clinical outcome of how the patient is doing at 6 months and later follow-up. We have, it depends on what field you're looking at. For example, if you coil a bunch of brain aneurysms and half of them recur 3 or 4 years later and need to be readdressed in some way, that is something important that you have to know about. And we look at we are also part of many clinical trials for brain tumor and for functional neurosurgery. So that part is more scientific driven and has, I think, limited utility with discussions with hospitals and insurance companies, but they do like to see some academic output. And again, during the arbitration process, if you are at a teaching institution, if you do have fellows, residents, that can be viewed upon favorably by the arbiter when determining a reimbursement. We used to have 2 full-time employees looking at our outcomes data for spine. Due to the exact same considerations Dr. Abrahams mentioned, eventually that fizzled out. But I think that's going to have to start back up, especially with spine. Spine-related outcomes are the hardest to come by because they're not as obvious, and a lot of them are very subjective, patient-reported data. And you need to have, it is Herculean, and you need to have at least 2 or 3 full-time employees just to start accumulating that data prospectively. And it's even worse retrospectively if you go back several years like they did. So I applaud the effort, and I think we're likely going to follow in your footsteps with respect to the spine outcome.
Yeah, I'm curious if you can, these are difficult decisions, and you've got many partners, and I know there's obviously different structures in private medical practices, but it's not as if, Dr. Karimi or Dr. Abrahams, you can wave a wand and everyone sort of lines up and does it. Can you just share how you've been dealing with some of these discussions or some of the reactions that your partners have had around No Surprises Act and things like consumerism, and how you're navigating those discussions? Because I know it's not easy to drive alignment.
On our side, I can tell you it's very difficult because nobody wants to deal with anything except taking home a big paycheck. And when people get a big paycheck, they want to blame somebody, and I'm frequently blamed in this practice. The problem with our group is that we took a lot of physicians who were in network and we took them out about 5 or 6 years ago. And that was when it was paying the best. And then you had physicians who were taking call, doing complex cases and making a significant amount of money per case. And that was directly correlated to our ER exposure. And for out of network in New York anyway, it's about an 18-month to 2-year cycle. And most of our out of network that's not elective goes, we have to appeal, and it can take up to 2 years. But once you change your practice, so for instance, if you take 10 nights a call and then you go to 2 nights a call per month, it's going to take about 2 years to see that transition. And that's what happened to us at the end of last year and the beginning of this year. And, you know, Reza has a very good understanding of the New Jersey out of network. And I have a decent understanding of the New York out of network. Most physicians don't. They do not understand it, nor do they want to. They want to look at their monthly collections and see where's the money? Why am I not making the money I made a year ago? And I think the thing I learned is years ago, I had a great year. And then the next year, I had a bad year. You can't predict what's going to happen. You can't correlate it to the number of cases you do in private practice. That's where I think is frustrating. I think physicians, surgeons in particular, have to become more enlightened with the other business models they can bring to their practice. And of course, that takes risk, because you have to make it an investment, and you may have to invest $250,000 to $500,000, and you may not see that for 6 months to a year. And I think we have to reset ourselves. Yes, become experts in billing, out of network billing, and making sure you really see from beginning to end that super bill once it's submitted, who's paying, and you have to see what your reimbursements are every 3 to 6 months, what your average Aetna payment is, what your average Blue Cross, like you have to see those numbers and follow those. And I would bet 90% of private practices don't have that number.
Yes, as we were talking about this webinar, obviously there's no surprises, but I think there's a lot of surprises that don't need to be surprises in practices, and you've just named some of them, Dr. Abrahams, right? In terms of how you look at data, how you plan as a group, and how you get more organized from the business side of this. As a lot of our clients say, the market is a vicious truth teller. And it's one thing to just show up and do your job. It's a whole other thing to have to sort of step back, and it's overwhelming. But I don't think there's a choice anymore, especially in private practice. Now, especially in light of the No Surprises Act, I think is probably not an unfair statement. Dr. Karimi, how about others in your practice, how these conversations go, whether it's around marketing or outsourcing billing or making investments, and how you're bringing folks along? It's not easy.
Right. So we have a partnership structure where everybody, is the partners are all equal partners, and then we vote, and majority is sufficient to pass something for most issues. Luckily enough, most of us are on the same page. The interests are aligned. However, there are some people who are less on top of the financial implications of certain decisions. And it sometimes there are difficulties with exploiting things even when we have the data. Lately, what we've done over the last year, we actually had to outsource our billing. It became, even where we had almost 10 full-time billing staff in addition to the surgical coordinators and the people who would code the case, we could not keep up with all the insurance denials. We just couldn't. And these were in-network denials, out-of-network denials. We just got pelted with these things. We had to outsource our billing to a specialty organization that could handle the volume and complexity. That being said, when we did that, we then had access to a very powerful business intelligence dashboard, which does exactly what Dr. Abrahams was talking about. Which payers are paying, which payers are not. Are emergency cases paying? Are they not? When we see patient with United Insurance, how's that going when it's an elective case versus an emergency case? And the largest question of, does it make sense to continue providing 24/7 emergency on-call services? We cover 6 different hospitals, and we provide 5 on-call physicians per day. Pediatric neurosurgeon, 2 adult neurosurgeons, and 2 vascular neurosurgeons, 365 days a year. If the and the reason that was economically viable to do that, it's not like it generated all of our cases. Only 40% of our clinical volume is emergency or inpatient surgeries. The economics of covering on call were favorable. About 20% of those patients have no resources. So those are cases where you just have to do it, get the patient taken care of, stabilize them, and even in most cases, provide long-term follow-up and even elective outpatient surgeries free of charge. If the economics of covering an on-call emergency basically evaporate overnight, so does our ability to provide that level of care in the emergency room setting. You have to be aware of where the money is coming and where the money is going. You need profits and loss analysis on your investments, your physicians, and you really need to keep your finger on the pulse of the insurance companies. We found out, I mean, we're a group of neurosurgeons. We're all conscientious. We all put the patient first. It took us 7 months to realize that the insurance plans we were in network with were only paying us for 40% of the operations we did. And that's when we were just being doctors, which is not, I think by definition, we're not businessmen first, we're doctors first. But when we started to look at these things, it was completely eye-opening. And now that we've seen what we've seen, you can't unsee that. And you realize that you need to put in more time, more hours, more business intelligence, more analysis, and sometimes making painful decisions to stop doing things that are completely operating at a loss and to start doing things that you haven't done before and taking risks. I think other areas in medicine have done this before us. There's a reason why in neurology practices, not neurosurgery, but in neurology practices, everybody's getting transcranial Dopplers and carotid duplex studies. And we would look at this and say, well, why are they even doing this? What's the indication? Well, it's an ancillary revenue stream, and it's small numbers here and there, but over a year, these things add up. In my practice, we weren't doing anything ancillary other than our participation in some surgical centers. We weren't doing neuromonitoring. We were doing physical therapy for years, but it was break even because we didn't know how to run it properly. We were doing some bracing, but it was operating net zero. We looked into doing imaging, but for various reasons, we found out that imaging was likely to not be profitable unless we joined forces with other groups in the area. But these are things we have to look at as smart investors, because the revenue stream, as it was for us, is not going to exist, in the years going forward.
Yeah, that's very helpful. Dominic, I want to throw this over to you before we take just a couple of questions. At Withum, you're a partner to many practices. How have you seen sort of the business side of this change, or the reaction start to change about the need for more partners like Withum in this discussion going forward?
Yeah, great question, Dan. And the key for us is accurate and timely data, right? And as Dr. Karimi and both Dr. Abraham said, you need to know exactly what you're getting paid, how to accelerate that cash, and even more importantly, around the denial side of it. And if you don't have the transparency into that data, and we're seeing that with all the large physician groups, it's difficult enough to get paid in a timely manner, but if you don't have clear insight into that data and really have the ability to understand what you're getting paid for, what you're being denied for, it's very difficult. So we're starting to help with a lot of tools around that. When you bring all these disparate systems together, how can you then give the information back to the owners, to the shareholders, to be able to make those changes? I've seen it firsthand trying to get alignment among all shareholders, and it's very hard to get money invested into something until they can see the ROI on it, as both physicians said. But it's absolutely more important than ever, because really what we're talking about here is margin pressure, right? And you're not going to be able to make it up with volume. It's going to get more difficult on a go-forward basis. And we continue to see many large physician practices struggle in terms of, and I applaud, Dr. Creamy and Dr. Abrahams, because they have the understanding and the business insight of what it takes to run a practice and the importance to have that accurate and timely data. So, for us at Withum, we continue to really work in this area to be able to, we call it, to be able to get paid in a timely manner for everything that you're supposed to get paid for. And we all know it sounds so easy, but it's so difficult. And if you don't have the up-to-date technology and processes and workflow, irregardless of the No Surprises Act, it's always been difficult. Now you get your revenue cut, it's even more important to collect every dollar that's out there.
Yeah, that's great. Rachel, I wanted to see if we had any questions in the final minutes remaining from the audience.
As of right now, we don't, but yeah, we have about 4 minutes left, so feel free to write in your questions now. Are there any commonly asked questions that you guys want to tend to?
Yeah, so I have one question. We talked a lot about clinical ancillary revenue. The other thing is, with the corporate practice of medicine in both New Jersey and New York, I know Dr. Abrams, and I would assume Dr. Creamy's structure has an MSO. Some of the things we're seeing out there are from other large physician groups is if you have that chassis and if you have that foundation, can you create incremental revenue by potentially providing billing services for other practices to sort of, reduce their overhead? The other thing we've had around is a medical malpractice. The average neurosurgeon can pay upwards in excess of $200,000. The other thing is, pooling together of more physicians, again, to try to decrease or increase non-clinical revenue. So I turn it over to either one of our here to talk about
that. Reza, you can go first.
Well, there's a lot to unpack there. We never did an MSO because we didn't have the need for it unless certain opportunities came up, but we've looked at it, 100 times, it seems. Honestly, with the billing and collections, I don't feel that we as a group have the energy to start rebuilding an effective collection apparatus right now. We were unfortunately in a position where during COVID and shortly thereafter, we had major deficiencies in how we were billing and collecting. And then once we gave it to a group of professionals, although they are expensive, they have been doing a fantastic job. Of course, if everything in the future becomes very simple, that everything's paying at 2x, 3x Medicare, we don't have a need for that anymore. But we haven't looked at MS, kind of developing a business in the MSO and selling it to other groups because they're all looking at their own MSOs. With respect to other ancillaries, I'll tell you, we actually hired, there's a lot of considerations with getting in other types of positions. We have 2 physiatrists in our group who are pain management physiatrists. They're excellent. They're fellowship trained. One of them was established in practice. The other came out as a fellow. And we tried to capture some of that business internally. The problem is that it really turned off a lot of our referring doctors who happen to be pain management doctors. So it was a real tightrope act to convince our referring doctors for spine that we weren't taking any of their business by hiring our own physiatrists. Most of them understood after some time, but some of them did not. In addition to that, when we've looked at profit and loss analysis for them, they're just net zero. They're really bringing in what they're costing to do. There's other costs. When you bring in a physiatrist, you need x-ray, you need the equipment for the x-ray, you need to have a lead-lined room, architectural engineering, and an x-ray tech. So that's probably why it's been net zero for the physiatrist for the first couple of years. Hopefully that changes. We have a movement disorder neurologist who's also operating at net zero, not profitable and not operating at a loss, but that's to support our functional neurosurgeon who needs a neurologist in order to practice his specialty of functional neurosurgery, which is mainly Parkinson's disease, deep brain stimulators, effectively. So the other ancillaries for us are physical therapy, imaging, concussion is one. We are in the process of trying to find a way to make that economically feasible. But with the potential disruption right now of the No Surprises Act, everything is really on pause until we see what happens with these arbitrations. How many of them are we going to win? Do we need to do a 75% discount, 50% discount? What are the economics going to be? Are we still going to be taking call for 6 hospitals? If really that it comes with a huge volume of charity care work that is unescapable due to EMTALA. All these questions need to be answered first before we start making those sort of larger investments. For now, the only thing that needs to continue full speed is the marketing, for sure.
Yeah. Well, Dr. Karimi, Dr. Abrahams, and to our guests, we're just about, we're a minute over, and I think we could probably talk about this forever, but I know Dr. Karimi and Dr. Abrahams are, Dr. Karimi is in the halls waiting to do his next procedure. Thank you so much for your time. Thank you to our audience today, obviously a very important topic, and thank you to our partners at Withum for doing this with us. And please reach out if you have any questions. We will be sending along the recording, and thank you for your time today, everybody. Dominic?
Thank you. Yeah, I just want to second thank you to both physicians and to Dan and Sage Growth Partners for helping us put this together. Really appreciate it.
All right, everyone, have a great day.
Thank you.
Thank you.
Bye-bye. Thank you.
And we got a few other questions that we will answer via email to be mindful of everyone's time. Thank you and have a great week.
Thank you.